I think we're ready.
Okay. Hi, everyone. Welcome to Shaking Off Stigma, or SOS.
I think she said, Kate just
Hold on.
said, hold on. Yep.
Thank you. I wasn't sure how to interpret that first message. Go ahead. Okay. Hi, everyone. Welcome to SOS, Shaking Off Stigma, our initial conversation for grandmothers with reproductive rights. This program series brings together women of different generations, as you can plainly see, to have candid and unedited conversations about the forces shaping our lives, work, and activism. Our hope is to reduce stigma, shame, and secrecy about the lives of women and to build connections across age differences. We hope you enjoy this conversation. I'm really looking forward to it. We'll start briefly introducing ourselves. I'm Connie. I'm a doctor in Western Maine. I have been a physician here for 30 years and did a lot of things before medical school. So I'm 73 years old. I have been involved in activism for at least 53 of those years, and am really looking forward to talking to Karissa. Karissa, you tell us about you.
Yeah, so hi everyone, I'm Karissa Rajagopal. I'm a fourth year medical student from a medical school in Maine, and I'm originally from Ohio and then traveled up to the East Coast for school. Also been an activist, I think, since I could walk. And I really am excited to hear about Dr. Adler's experience and talk to you all. And yes, I'm 27, because I think age does matter in this space, right?
So the first thing we were going to talk about, and I'm really interested to hear from you about, Karissa, is what medical school is like. So I started medical school in 1979. I was then 30 because I had done a bunch of other, well, I mean, that's interesting too. Every time we did aptitude tests in high school, it came out that I should be a doctor, but then everybody would say, oh, but that's silly because you're a girl. So I majored in history, and I graduated from university in history, and then spent 10 years doing all kinds of political things, which is enough for a different day. And but then started medical school in 1979. So in my medical school class, about a third of us were women. There were about 5 people of color, as I recall. Almost everybody had gone directly through college to medical school. I remember distinctly so when I started medical school, I was a 30-year-old single parent of a 6-year-old. And I'm pretty sure the only one in the medical school class who had ever gotten food stamps. I remember sitting next to this male student the first day, and everybody's going, oh, what school did you go to? What school did you do? Blah, 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 blah. And I said something about having a 6-year-old, and he said, oh, what does your husband do? And I said, I'm not married. And he said, but you said you had a child. And I went, you'll learn this later in school, but it turns out you don't have to be married to get pregnant. But that was sort of what it was like. There was virtually no socioeconomic diversity. It was interesting. So tell me I bet your medical school class is pretty different.
Yes, I mean, so I think when it comes to gender or sex, we actually have more females in my medical school class than males, and my dean is a female. So I think that as what I've noticed so far in healthcare is that we're really taking over the space, which is exciting. But there's still like a lot of subtle things that I think like I've experienced. For example, my best friend in med school is a male, and we'd always go to professors' office hours, and the professor would only talk to the male or answer his questions or support him. Or, you know, as a third year medical student, when I was trying what specialty to go into, everybody asked me, well, when I said I wanted to do OB, everyone's like, well, don't you want a family? Don't you want time? And, you know, so I don't think my male counterparts get that as much.
Yeah.
So, there's still work to be done, but I think for the most part, we're at least getting into medical schools and we're definitely breaking down that. I do think it's incredibly hard for parents still. So I really am impressed and excited that you accomplished that as a parent. A couple of my friends have been pregnant throughout med school, and it's kind of a constant fight getting paternity leave, like, breastfeeding rooms, things like that. It's still a struggle that they have to encounter. And there's still a lot of stigma around having a child during medical school. Like, it's supposed to take over your whole life. Is supposed to be medical school, but I think that everyone has a right to have a child, obviously, if they want one. And so it's been really sad and kind of humbling to watch their experience go through that.
We actually, one of the residents that I had in medical school, in his residency program, they were not only not allowed to have family, but they were not allowed to be in a relationship if they went to that residency. That's how much people, the thought was it had to be your everything. But a follow-up, I want to ask you about faculty. We had virtually well, there were a couple in the basic sciences, women in the faculty, but academic medicine was entirely male. Is that still true?
I don't think so. I think that it's pretty split. I don't know if it's unique to Maine. I know it isn't extremely unique to Maine, but we do not have a lot of faculty of color, and that's something that we're actively trying to work on and improve, because we don't have a large Black community at our university, but there are a lot of I'm Indian, first generation. There's a lot of first generation Indian students, Chinese students, not a lot of Latinx students, but like, I think that's something that we're working on. I think that I started a lot of initiatives at my medical school and was skeptical about how they would be received. But I think for the most part, people are eager and ready to make the changes of a more inclusive environment for medical education, because they're seeing the harm that comes with not having your doctors represent the patient population. Like, doctors that are parents have a unique experience to care for their patients. Having the experience of being on food stamps. Before this, we were talking about how I'm on, as a medical student, I'm on main care. And so we need doctors to kind of and break down that power dynamic and all those things. So I think we're starting to reimagine and reframe what we should be doing as doctors and who should be a doctor, and all these ideas of shoulding that we do. I go to University of New England. It's in Biddeford, Maine. Sorry, someone just chatted that.
Yes, I just saw that, and I went to Tufts in Boston. So the socioeconomic stuff, I think, and especially thinking about diversity and equity, there's more and more studies, which I think are so interesting, about the effects of having your doctor be someone who looks like you, especially for Black women in birthing. And kids. Have you read that study about babies, African-American babies have a higher chance of survival in that first month of life if they were cared for by physicians of color?
That's amazing. Well,
Yeah,
because sad, but it's also just
yeah. And it sort of blows the whole thing about it's conversation, blah, blah, blah. These babies are not talking to anybody.
But there's a lot that happens there. People always ask me what's the hardest part about med school. And when I went into med school, I thought it would be the hours, or, the isolation, or studying super hard and all the medical information. But I think it's the lack of commonality or passion that I have for my patients that maybe some other physicians don't, like the lack of understanding. I mean, I grew up without a lot of money. So there's a lot of things that I kind of there's a lot of conversations between the lines that happens with me and patients that I don't see happen with some of my affluent attendings, or like attendings are just people who look over me as a student. But, and that's what's really challenging, because you don't know what you don't know. And I see a lot of that in medicine when it comes to these social topics.
Yes, yes.
And And so that's why I joined a lot of this work, because I didn't know a lot about it, and I wanted to be a better physician for my future patients. But yeah, I think there's a lot of work to do.
That's really interesting that you're still finding that. I mean, I went into medicine because it was a good way to be an advocate for women. I didn't go into, I love the science, but I didn't go into it for the science. I went into it because I knew that was, I could have a stronger voice for women and do more for women that way than in most of the other ways that I could think of. And that's been true, which is pretty exciting.
So I'm interested what it was like for you when you were in med school around abortion conversations or getting abortion education in medical school.
It was not discussed a lot, in hardly at all, in medical school. I mean, reproductive health was 1 week of anatomy lectures sort of in second year. I mean, it was nothing. The thing that and I will talk about abortion directly, but the thing that I remember the most about that week, and was one of the big differences, I think, in education now, is the, well, there's the misogyny, of course, but also the attitude about LGBTQ people. There was a lecture about homosexuality, and in it, the lecturer said something about gay men, and then said something about, of course, you have to be careful to keep them away from little boys. And I lost my shit. I really did. I was in the front of I sat near the front of the classroom, and I stood up and just let it go. I mean, I said, how dare you imply that gay men are pedophiles and that there are more gay men raping kids than straight men? Excuse me? It was, and then I heard somebody behind me go, I didn't know she was a lesbian. It was great. It was fantastic. And there were, of course, gay people in my class, and they were all closeted. They knew they would not get residencies if anybody knew they were gay. And actually that ended up being, it was useful. I ended up being able to make a lot of noise and be very loud about those issues and protect some other people who really couldn't. But it was awful. And of course, the AIDS epidemic happened while I was in medical school. I started medical school in 1979. And we had, in the hospital where I was doing third year medicine, we had their first AIDS patient with with pneumonia in the pneumocystis carinii, I can say it, pneumonia. And we had a guest attending, and the attending would not do rounds on him with us. He did the wages of sin is death thing, and would not take care of this patient. So that's, I think, I'm assuming that's one of the bigger changes in medical school now. I mean, it was horrible.
Yeah. Oh, I'm so sorry. I mean, I think that it has changes. We have lectures now, but that's actually one of the changes to the curriculum I work a lot on, like bringing pronouns into all of our patient encounters was a huge battle. And a lot of providers were like, I don't get why I have to do that. I should only ask patients that I don't think, that I don't know what their gender is or something like that. I'm like, no, you should ask everybody that. And like cultural change and shift in education, like it just, there's such a resistance to learning sometimes in medicine that I don't understand. I'm like, I'm telling you, here's literature that supports what I'm saying. You're a scientist. Like, listen to this literature. We're not serving our LGBTQI community. You might say you care about all your patients equally, but this data is telling you otherwise. So you need to reform how you practice. And there's just this resistance to that still.
Yeah. Mm-hmm.
Yeah. But I think that just goes back to like human nature of like not wanting to maybe accept some of our flaws or being uncomfortable with some topics that we're not interested in. Just to shift really quick, a question was about breastfeeding, if it's covered during our time in medical school. And that one's for you, Connie. And then another,
we're talking about breastfeeding?
Yeah, another question is this discussed? So I guess I can go first quickly. Not really. I mean, we talk about like the hormone pathway of like what stimulates lactation, but no.
Well, I think there are a lot of things that are not covered in lectures that are really covered in, in the clinical years. I mean, certainly doing pediatrics in my clinical rotations, we talked about breastfeeding a lot. It's been a long time. I don't remember whether we talked about it all or significantly in the classroom situation, but certainly later on in the clinical rotations. I had my second child during medical school. So I remember sitting in the ICU pumping breast milk, and mostly folks were horrified that, but the pediatricians were great. The pediatricians were great and gave me a lot of support while I had a young baby, a newborn. I mean, I did one rotation with her strapped to my chest because I had no alternative. And they were terrifically supportive. But yeah, and by and large, people were not. But I do remember that, yes, we certainly talked about it.
Yeah, I think maybe it'll come during my residency as I get more specialized into how I practice, because the first 4 years really in medical school, you get trained as more of like a general practitioner and a bunch of knowledge. So then after my 4 years in med school, I'll go off to what's called residency. And then hopefully I'll get to learn more about that. Yeah.
I suspect you will, especially if you do decide to do OBGYN, because I mean, that's a big part of OBGYN practice is helping women through lactation and supporting lactation.
One thing actually around breast chest feeding that I've recently learned is I had a neighbor this past year who is non-binary and taught me so much about taking gender out of birth work and how as an OB or birth worker we can serve our LGBTQI community better. So I'm actively trying, and please feel free to call me out, anyone, to take out some of the gendered language that's aligned with reproductive justice. And so I think that's breast chest feeding is something that I'm trying to incorporate more into my language. So
thank you.
Yeah.
Thank you.
I struggle with it though, clearly.
Yeah, right.
Yeah. Okay, so we talked a bit about what med school is like for you. I have a sense of why you wanted to go into this work, but I don't know if there's anything else you wanted to share about it.
Well, I actually, so I am a family physician. I didn't do OBGYN. And I did that quite intentionally because given the OBGYNs that I knew in medical school, I thought that I would probably commit murder if I did an OBGYN residency. They were just a hateful group of men. And some of the stuff, I mean, we could talk for hours about what birthing was like back in the day. I've been through a whole lot of stages of birthing in the United States, from scopolamine to, all kinds of stuff. I mean, we had one attending who everybody got a spinal so that he could pull the baby out with forceps. I mean, it's unbelievable. Anyway, but they were by and large, they were all men, for one thing. And they really saw OBGYN as a surgical subspecialty. And so anyway, I decided not to do that. I did family practice and did a lot of obstetrics in family practice. And I sought out extra rotations in family practice. And then I was in the National Health Service. That's how I went through medical school, was through the National Health Service. So in my service time, I was in a small town in Washington, and they were very short of OBs. So I was able to, I learned how to do C-sections and tubals. And so I was able to do and have continued to do a lot of surgery for a family doc. Um, but never did an OBGYN residency. Interestingly enough, when I wanted, in my residency, when I wanted to learn how to do abortions, there was no OBGYN in the state of Maine who would train me how to do abortions. And so I had to go, I commuted to Boston to learn because no one would teach me how to do it.
It's really interesting you say that about the OB field, because actually I wanted to be a family doc. So the moment I walked into med school until probably my last month of third year, because when I was in family, all I wanted to do was like work in reproductive health and things like that. And then I did kind of fall in love with the OR, but that was my biggest reservation, is there is historically this energy in OB field. And even though now it is female predominated,
Yes.
Like most residencies are mostly females,
Right.
It still has a very intense culture, which I feel like is part of the reason that I'm driven to go into that, because I really want to change that culture. You know, you want the person helping you through your birth process or doing your female physicals to be your ally and your advocate. So it confused me why it had this intense energy. And grant, there needs to be great OB/GYN surgeons. That's wonderful too. But we also need, you know, great abortion providers and great people to do women's health and all these things. So I feel like I can maybe change some of it and bring kindness. And yeah, and I think it goes back to what you said about it was male predominated, right? So a lot of times what we see in medicine or in the world in general is when women are taking back a space, we feel sometimes that we need to act like men and act that aggressively. But you know, like Angela Davis is my ultimate feminist like guru, but and then she talks a lot about that, about like we don't need to participate in some of the harms that have made the world the way they are. So hopefully I can change some of that energy and we'll train with a lot of family docs and midwives and people that practice more of that family holistic energy and full life spectrum practice. So we'll see.
Yeah, no, I mean, I absolutely think it can be done, and it is different. I mean, OBGYN residency now is predominantly women, and that does make a difference for sure. But I think you're right. You have to keep your guard up to make sure that it is also that you're always questioning, and that people are thinking about the folks that they're taking care of in a really open way.
Yeah. And I feel like,
and I think, you know, there were all of the issues of men versus women, but there are also the class issues are interesting and powerful. I mean, people who have grown up in suburban environments of privilege do not expand their thinking to include folks who haven't, and are very dismissive and demeaning in their attitudes about women who come from a very different place. I mean, you certainly see that here, you see that everywhere. And a huge issue for women of color.
Yeah, I see that a lot with pain in particular. You know, like women's pain in general is just, you know, it's a period. Like, of course it's gonna hurt. Well, for some people it hurts a lot more, and it's our role as doctors. That's what I see our role is to like find people's health and happiness and allow them to function in society, and not just. So that always just grinds my gears is when people are just like, well, yeah, labor really hurts, or your pain really hurts, or sure, you're in pain, you know, like those are the issues that I see time and time again. And I don't think that
there's a lot of research on that. Of course, you probably have seen that with the physicians in the ER in every stage give women of color, less pain medicine.
Less pain medications, or even something like a lot of I was out with my aunts last week, and I was talking about how one of the surgeries I love to do is like a bladder sling, because and it's such a simple surgery, but so many women experience urinary incontinence and they just think it's a part of their life. And so many times, this one patient was like, I just want to go on a hike. That's all I want to do. I'm so active. I just want to be able to hike without like peeing my pants. And after we did that procedure, she was crying and so grateful. And it was so simple, but she never knew that was something to talk to her doctor about. Because as young females, we aren't educated on our bodies. We aren't educated on what's going to happen to our bodies as we age. And so we think we're just supposed to suffer with these pains and aches. And OBs have all this knowledge, but sometimes we don't tell you about all the services we can offer you. And so I don't know. I think we need to be educating even from a younger age of what to expect, like a period happens sometimes and young people are like, what's happening? I'm like, no one warned you that this is going to happen. So yeah.
While I was in training, the research came out that said that the average age of menopause is 52.
Mm-hmm.
So that was, I don't remember exactly, but probably sometime in the 1980s when people discovered that. Mm-hmm. And I thought to myself, if a man's dick fell off at some age, we would have known that age a long time ago. Yes. The research still in women's health is appalling. And
around like estrogen, supplemental estrogen in menopause. My attending was telling me, like, really broke down the research for me, and she was like, it's okay for them to be on estrogen, like this amount, if they don't have these comorbidities. But so many providers are just like, nope, there was this one study that says it's not good, it's going to give you a heart attack. But it should be up to someone's decision. Like, you have to give them all the facts, because for some people menopause is really painful again, and it's their option if they want to be on that medication and accept the risk of cardiovascular harm, right? Like that.
Yeah, well, like everything, we've gone back and forth. That pendulum is, oh my God, so many times. Right. It's like birthing. I mean, the styles of birthing have changed so many different times.
Right.
So I had an interesting conversation. My daughter mentioned yesterday that she had just met a woman who is an ER physician, and she wanted to make sure that she knew how to do abortions.
Mm-hmm.
And she went to a state university in the West. I don't even remember which one it was, but the university had gotten a lot of money. The medical school had gotten a lot of money from a donor with the agreement that they would not teach their residents how to do abortions. So I just bring that up. The anti-abortion folks who have a lot of money, you have to be careful, even in residency, to make sure that the residency that you choose mirrors the things that you want to learn how to do and you want to do with your life, that they're going to let you do what you want to do.
I appreciate that warning. It's something I definitely consider when applying to my next step. In regards to abortion training right now, in our first 4 years of medical school, we had one lecture on it, and it wasn't what bothered me. I absolutely love and respect, and they are my absolute heroes, the two female physicians that gave the lecture, but it was presented as an ethical lecture. It was like, and it shouldn't be that. It's not this siloed procedure. It is a procedure and a service we provide as physicians.
Right.
And a lot of the cases that they presented were these extreme cases, of like someone who had been assaulted or, something like that. But like, I've only had the opportunity to work in an abortion clinic, I think like 3 or 4 times. And most of the people were already mothers or, there weren't always this extreme story. So that representation that my classmates now have, I hope they don't carry on with them for the rest of their career, because it was one lecture. We do have a Med Student for Choice club on campus, and they, we meet regularly, and we do a lot of our own education, our own reading and book clubs. So, but then there's always still a little bit of pushback, and it's still a little bit taboo to talk about it. I'm a pretty unapologetic person, so I talk about it openly, and I often get that feedback from people like, oh, when you're applying to residency, maybe like rein it back a little bit on your abortion talk or your advocating hats and things like that. And my response is usually no, because like that, for me, residency is where I'm going to get the bulk of my training. And if they don't accept that part of my identity, I don't really want to be there anyways. So there's definitely pockets. I mean, this one residency program won't even teach you how to do IUDs postpartum, right? I mean, what else are you doing as an OB if you're not providing IUDs and LARCs for your patients that are requesting them? So there's still a lot of work to be done in it. And my goal in curriculum reform for medical school is to stop taking some of these topics to be like a lunchtime, deep ethical conversation. Like this past year was the first time we actually talked about trans health, endocrine and hormone options. And we talked about it in the endocrine block, in the endocrine section. And we talked about, and a pediatric endocrinologist gave the lecture, and it was that. It wasn't like, is being transgender okay? Like, that's not how it was presented. It was like, this is how you're going to provide hormones for your transgender patient. That's it. That's what we do as doctors, right? And that's how I would like abortions and abortion work to be taught in medical school.
We did not have a lecture on how to do hormone therapy for transgender people in my medical school.
It was the first year. It was so exciting. I cried the whole time.
Bravo. It's wonderful. I'm so happy I'm so happy.
I mean, I'm really grateful at UNE they really accept and welcome a lot of some of these and they're not progressive ideas, some of these necessary topics that we need to teach in med school. So yeah.
Karissa, I think we actually could talk for another 6 hours, and I would love that.
Okay.
But we were supposed to more or less keep this to half an hour. It would be fun. I don't know if folks want to do it, but it would be fun to talk about specifically the issue of activism in medicine. Mm-hmm. And I would love to do that more with you at some point.
For sure. If there's not any other questions, Kate, should we just log off here? But thank you everyone for attending, and thank you so much for hosting me today. I'm so grateful to have this conversation and honor the generations before me that have given me the shoulders to stand on. So thank you.
And I should say also, if I can ever be personally helpful to you while you're making these decisions, please contact me.
So much. Yeah, I will for sure.
I have done that with a lot of young women going through this.
Great. Yes, it's going to be a process, so I could use all the help I can get.
Absolutely. Take care.
Thank you. I think